Welcome to NSG 315 Study Session 10. In this study session, we'll be talking about lower respiratory tract infections. Introduction. Conditions affecting the lower respiratory tract range from acute problems to long-term chronic disorders. In this study session, you'll be learning about the anatomy of the lower respiratory tract and diseases of the lower respiratory tract. Learning outcome for study session 10. At the end of this study session, you should be able to 1. Further explain the anatomy of the lower respiratory tract, and secondly, discuss the disease of the lower respiratory tract. Review of the lower respiratory tract anatomy. The lower respiratory tract consists of bronchi, bronchioles, alveolar ducts, and alveoli. All structures are within the lung tissue, except the main stem, the bronchi, right and left. The lung is divided into 3 lobes, the upper, middle, and lower lobe. The left lung is divided into 2, the upper and lower lobe. Exchange of gases. No exchange of gas occurs until air enters the respiratory bronchioles. Anatomic dead space, that is VD, area of respiratory tract from the nose to the respiratory bronchioles. Conducting pathway, trachea, bronchi, segmental and subsegmental bronchi. Surfactant. The lung can be conceptualized as a collection of 300 million bubbles, that is alveoli, each 0.3 mm in diameter. Naturally, the alveoli have a tendency to collapse. The alveolar surface is composed of cells that provide structure and secrete surfactant. Surfactant is a lipoprotein that reduces the surface tension in the alveoli. It reduces the tendency of the alveoli collapse. Secretion of surfactant is stimulated by the stretching of alveoli during a sigh breath. Diseases of the lower respiratory tract. Lower respiratory tract infections are the most common causes of death in the world. Chronic lower respiratory disease are the 4th leading cause of death in the US. Pneumonia ranks the 7th leading cause of death, despite availability of antimicrobials. TB, though curable and preventable, is a public health threat globally. Acute bronchitis. Inflammation of the bronchi due to an infection occurs commonly as a consequence of upper respiratory tract infection, a potentially serious problem that can lead to respiratory failure. Common causes: viral infections, rhinovirus, influenza, bacterial infections, streptococcal pneumonia, Haemophilus influenza, which is common in non-smokers, mycoplasma pneumonia, and chlamydia pneumonia. Pneumonia. Acute inflammation of the lung parenchyma is the 7th leading cause of death in the US. Etiology: a break in the normal or defective respiratory defense mechanism. Normal defense mechanism: filtration of the air, warming, humidification of the inspired air, closure of the epiglottis over the trachea, cough reflex, mucociliary escalator mechanism, secretion of immunoglobulin A, alveolar macrophages. Diseases: leukemia, alcoholism, diabetes mellitus are associated with increased frequency of gram-negative bacilli on the oropharynx. Summary of predisposing causes: 1. Aging, air pollution, altered consciousness, alcoholism, head injury, drug overdose, bed rest, and prolonged immobility. 2. Chronic diseases: chronic lung disease, DM, heart disease, cancer, end-stage renal failure. Number 3, HIV infection, immune suppressive drugs, example steroids, cancer chemotherapy. Number 4, inhalation or aspiration of noxious substances. Number 5, malnutrition, smoking. Number 6, trachea intubation, in endotracheal intubation and tracheostomy. And lastly, number 7, upper respiratory tract infection. Causative organisms stroke mode of entry. The organisms that cause pneumonia reach the lungs by 3 methods. 1, aspiration from nasopharynx or oropharynx. 2, inhalation of microbes from the air. Examples, Mycoplasma pneumoniae and fungi pneumoniae. Then lastly, number 3, hematogenous spread from a primary infection elsewhere in the body. Example, Staphylococcus aureus. Types of pneumonia. They are community-acquired pneumonia and hospital-acquired pneumonia. Pathophysiology of pneumonia. Pneumococcal pneumonia is the most commonest cause of bacterial pneumonia, caused by Streptococcus pneumonia, also called pneumococcus. It can affect the upper respiratory tract, the blood and nervous system. Organism is usually found in the nose and throat. 4 stages of disease process. Number 1, congestion. After the organism reaches the alveoli, there is an outpouring of fluid into the alveoli. The organisms multiply in the serous fluid and the infections spread. The pneumococci damage the host by their overwhelming growth and interfering with lung function. Number 2, red hepatization. This is a massive dilation of the capillaries. Alveoli are filled with organisms, neutrophils, red blood cells, and fibrin. The lungs appear red and granular, like the liver. Thus, the process is called hepatization. Number 5, gray hepatization. Decreased blood flow with leukocytes and fibrin consolidation in the affected lungs. Number 4, resolution of infection. Without complications, complete resolution and healing occurs. The exudates become lysed and is processed by macrophages. Normal lung tissue and function is restored. Clinical manifestation. Sudden onset of symptoms: fever, chills, shortness of breath, cough, productive of purulent sputum. Rust-colored sputum can be seen in pneumococcal infection. Pleuritic chest in some cases. Confusion and stupor in elderly and debilitated patients. On physical examination, signs of pulmonary consolidation such as dullness to percussion, increased fremitors, that is vibration of the chest wall produced by vocalization. Increased fremitors occurs when the lung is filled with fluid or more dense. Bronchial breath sounds and crackles. Complication develops commonly in individuals with comorbidities. Otherwise, pneumonia often runs an uncomplicated course. Pleurisy, that is inflammation of the pleura. Pleural effusion, that is transudate of fluid in the pleural space, develops in 40% of hospitalized patients with pneumonia. Usually, effusion is sterile, is reabsorbed in 1 to 2 weeks. Occasionally, aspiration by by thoracocentesis may be required. Atelectasis, that is collapsed earless alveoli of one or more parts of one lobe, may occur, which usually clear with effective coughing and drip breathing. Bacteremia occurs in 30% of cases with pneumococcal pneumonia and is associated with 20% mortality rate. Lung abscess, seen with Pneumonia caused by Staph aureus and gram-negative pneumonia. Emphysema, accumulation of purulent exudate in the pleural cavity, requires drainage by chest tube or open surgical drainage. Pericarditis, from spread of infecting organism from an infected pleura via hematogenous routes to the pericardium. Meningitis, a patient with pneumonia who disoriented, confused, or somnolent should have a lumbar puncture to rule out meningitis. Endocarditis can occur when organisms attack endocardium and the valves. Diagnostic studies. History, physical examination, at least chest x-ray, invaluable in the diagnosis of pneumonia. Lobal or segmental consolidation suggests a bacterial cause, usually streptococcal pneumonia or Klebsiella. Diffuse pulmonary infiltrate, most commonly caused by viral infection, Legionella or pathogenic fungi. Cavitary shadows suggest the presence of necrotizing infection with destruction of lung tissue caused by Staphylococcus aureus, gram-negative bacteria, Mycobacterium tuberculosis. Lower respiratory tract sputum for culture before antibiotics therapy. Sputum should be sent for culture as soon as it is collected. Pulse oximetry may show oxygen desaturation. Arterial blood gases may reveal hypoxemia, a PaO2 of less than 80 mm of mercury, hypercapnia, partial pressure of carbon dioxide in arterial blood, that's a PaCO2 of greater than 45 mm of mercury, and acidosis. Leukocytosis is present in majority of patients with pneumonia. WBC count of greater than 15,000 microliter, that is 15 times 109 per liter, with presence of bands immature neutrophils. Management. Obstructive pneumonia diseases include asthma, chronic obstructive pulmonary disease, example chronic bronchitis and emphysema, and cystic fibrosis, a genetic disorder. Triggers of asthma. Allergens. In about 40% of cases, allergic asthma may be seasonal. Exercise. Exercise-induced asthma. It occurs commonly after vigorous exercise and not during exercise. Air pollution. Example, cigarette, wood smoke, vehicular exhaust, elevated ozone level, sulfur dioxide, and nitrogen dioxide. Occupational factors. Example, wood and vegetable dust, that is flour, pharmaceutical agent, laundry detergent, animal and insect dust, secretions, etc. Respiratory infections. Viral or bacterial and allergy to microorganism is the major precipitating factor of an acute attack. Infectious causes, inflammatory changes in the tracheobronchial system and alter the mucociliary mechanism, thereby increasing upper responsiveness of the bronchial system. Nose and sinus problem. Allergic rhinitis, nasal polyps, drugs and food additives, gastrointestinal reflux disease. Summary of study session 10. In this study session, you've learned the following. 1. The lower respiratory tract consists of bronchi, bronchioles, alveolar ducts, and alveoli. Number 2. Lower respiratory tract infection are the most common causes of death in the world. Chronic lower respiratory disease are the 4th leading cause of death in the U.S. Pneumonia ranks the 7th leading cause of death, despite availability of antimicrobials. TB, though curable and preventable, is a public health threat globally. Number 3, the infections include asthma, pneumonia, and acute bronchitis. Thank you. We've come to the end of study session 10.